Okay.
Guys, can you hear me?
Maybe here?
Yes, I can, Huda.
You can hear? Okay, I think everybody is here already. Okay, if everybody is here, we can start. I have Dr. Thaya with me. Actually, I'm dialing from her office at Oasis Bangsa. Okay, so I think without further ado, I'll let Dr. Thaya to start with her training. So what we'll do today is it's going to be a very informal session. So if you have any questions along the way, feel free to stop her and ask questions. And then she'll address it along the way.
And if not, you can put it in that.
And if not, you can
put it in the chat, and then we can just
we can just go through the question. Okay. So it's either you stop her halfway when you have a question, or you can put it in the chat and we can address it at the end. Okay. So I think without further ado, I'd like Dr. Thaya to start her presentation.
Okay. So am I ready? Hi, hello, good afternoon, everyone.
Good afternoon, Dr. Thaya.
Good afternoon. Thanks for having me. Okay, so the thing is, this is going to be pretty informal, okay? So if anything you want to ask, please ask. And if you think I'm talking too much or too little, you can just ask me and I will just fill you in. So the talk for today is all you need to know and more. And these were the questions that Huda had given me that day. The prevalence of glaucoma in Malaysia. This was the kind of questions you guys wanted answered. Glaucoma disease, and I put in bracket progression. The reason I put progression in brackets is because this talk might not be able to, touch on that because it's very, a lot of stuff. Then different treatment for glaucoma. And especially you guys wanted eye drops, and which class of eye drops for which patients, when is patients given combination therapy, and which is when do you give single, and basics of glaucoma. This was the kind of questions that you asked. So we'll just start. Can you hear me? Are you all okay with that?
Yes.
Yes,
okay.
yes, very good.
Fine. Okay, so we don't really, Malaysia, the problem with us is we don't have much data about prevalence of glaucoma in Malaysia per se, but we tend to extrapolate based on our National Eye Survey. The first National Eye Survey was done in 1996. And here they actually looked at every age group. So all of us, all the ophthalmologists, the post-basics went to each little village, kampung, district, and all over Malaysia, and they did the study. And they reported the prevalence of blindness and low vision in Malaysia was about 0.29 and 2.44. And cataract was the major cause of bilateral blindness, accounting for 39% of total estimated cases. And then in 2014, we had the National Eye Survey #2, and this was done in collaboration with WHO. And they actually found that the commonest cause of blindness were untreated cataracts, 59%, diabetic retinopathy about 10%, and other posterior segment diseases, 8%, and glaucoma about 6%. Untreated cataracts, uncorrected refractive error, and diabetic retinopathy represented the commonest cause of moderate to severe visual loss. So this was the National Eye Survey 2, and it was done in patients above 50. So the National Eye Survey 1, which was the one in blue, did it in all ages, and the current one was done looking at people above the age of 50. So it doesn't still give us very much prevalence of glaucoma in Malaysia. So I just like to say that glaucoma poses a significant public health concern, as it's the second leading cause of blindness after cataract. And this blindness, unlike cataract, is irreversible. Cataracts is once you remove the cataract and you put in an intraocular lens, the poor vision will improve to good vision. So this glaucoma is a major cause of irreversible blindness. So I'm going to now talk about in the population in the world. 57 million people worldwide are affected by primary open-angle glaucoma. And by 2020, they expect this number to go up to 76 million people. And it's supposed to reach 111 million people by 2040. So you know that glaucoma is a disease that affects people as we age, and with better healthcare, people are living longer. So because of that, the number of glaucoma cases are going to go up. So getting involved in glaucoma eye drops, I guess it's a good business model. Although I'm saying that the open angle glaucoma is the largest number, the incidence of blindness is higher in angle closure glaucoma, despite it being less common than open angle glaucoma. Now, this is just across the border, our neighboring country, Singapore Malay Eye Study. And here they did, there were many population-based studies in Asia, and they were reporting prevalence of glaucoma based on different racial and ethnic. And this looked at Chinese, Indian, and other Asian population. So here the prevalence of glaucoma ranges from 2.4% to 5%. And most of the glaucoma cases were primary open angle glaucomas. In the Tanjung Pagar survey in Singapore, which is this famous Malay Eye Study, they looked at ethnic Chinese, and they reported that 3.2% of Chinese population between the ages of 40 to 80 had glaucoma, and 50% of them were open angle and 30% only were angle closure. Actually, before they started the study, they expected the angle closure to be much higher than the open angle, because that's what usually is seen in Asia, in China, and in India. So in summary, this study looked at glaucoma in the urban Malay population, and it was about 3.4, and this is comparable with other Asian population. So the most common type of glaucoma is open angle glaucoma, but the prevalence of angle closure was much lower in this particular study compared to China. And the worrying thing is more than 90% of people with glaucoma do not have a known history of glaucoma. So am I going too fast, or are we okay with it? Are you all okay, guys? Okay, never mind. So the prevalence of glaucoma, 50% of all glaucomas come from the Asian population, from Asia. So in contrast to primary open angle, which is usually seen more in Western countries, the most common type of glaucoma, which is open angle, primary angle closure is associated with closure of the anterior chamber angle and is known to have a greater propensity for bilateral blindness, and which leads to a huge burden to families and the society, and obviously to the country. So it's also estimated that the global population with angle closure would be about 23 million in 2020 and 32 million by 2040, and in which Asia accounts to more than 3/4 of the angle closure in the population. So that's a lot. We are talking about large numbers here. And to put the point across, this is the prevalence of angle closure in a study, and this is age group. So if you look at the 40 to 80, as people grow older, they tend to have glaucoma. And if you look at the angle closure, the females have a higher preponderance, and the older you get, the higher the chance. So up to date, angle closure is a worldwide vision-threatening disease with high prevalence. It affects about 17 to 20 million aged people in the world, especially in Asia. And in Asia, the female sex and aging, the older you are, it increases our risk of developing angle closure. So early screening in patients with high risk is needed for early intervention of angle closure, particularly in the Asian countries. So now the question that most of us would like to know is, do people go blind from glaucoma? So according to the best estimates, more than 200,000 people in the United States are blind from glaucoma, from about 4 million people with the disease. Worldwide, 6 million people out of 67 million people with glaucoma are blind. So this is literally 10 times, 1 in 10. And glaucoma is the second leading cause of irreversible blindness in the United States, but it is number 1 worldwide. It is ranked number 2 in United States because age-related macular degeneration is the major cause of irreversible blindness in United States, but the rest of the world, it is mainly glaucoma. So will I go blind before I die? Because that's what most of us want to know. Fortunately, for most patients, the answer is no. Blindness can occur from glaucoma, and that's what we are always telling, and that's what people think. If you look at the fear factor, right, one of the main causes of fear of aging is Alzheimer's, glaucoma, and cancer. So there are about 120,000 cases of blindness in the United States and 2.3 million cases of glaucoma. This represents about 5% of glaucoma patients. However, slight sight impairment is more common and it occurs only in about 10% of patients. Loss of vision can occur even with the best treatment. Despite that sobering fact, correct treatment and follow-up will stabilize the vast majority of patients in glaucoma, and most of the patients should not go blind before they die. That's if we treat them properly and we know what we're doing. So now in the Will I Go Blind again, in the EMGT, which is the early manifest glaucoma trial, about 60% of people diagnosed to have glaucoma eventually lose some vision, but it's important to emphasize that they lose some vision, visual function, but they do not become blind. So I would just like to say, what is blindness by WHO standards? Blindness as either eye vision worse than 20/400 or with less than 10 degrees of central vision field remaining. But many people can still function with all this. So blindness does and can occur from glaucoma, but it's a relatively rare occurrence if you can screen them early and we can treat them appropriately. So just to put things, we were talking about visual loss or visual impairment and compared to blindness. So this is a very good study that was done by David Crabb in UK. And actually you have loads of patients who actually have glaucoma all over the world in population, but they did the study in UK. But the visual impairment percentage is about 10%. So when they say visual impairment, it's like what I said, but blindness is about 4%. So 4% of the population can go blind, 10% can have severe visual impairment. When we talk about visual impairment, here we have the left eye in terms of mean deviation, and this is the right eye in terms of mean deviation. And here we're talking about mean deviation worse than -15 or something like that. That's based on visual fields, okay? So the thing I want to show you in this slide is we always like to put a stage of disease from early to late, and whether you're young or whether you're old. So if you're this is the point, if you're younger and if you have the disease, we need to keep you for the longer period of time. So that's why it's very important for us to pick up the disease earlier and to treat them, because we don't want them to go down to this functional impairment. We may have a bit of loss of visual function, but if we can pick them up early, then we hope that we do not go down to this thing. So if we can treat patients, we like to treat them, and we don't want the curve to be very steep. So we want the line to be a bit more rata, so it's not so causing so much of problems. So that is about prevalence of glaucoma and blindness and visual impairment related to glaucoma Do we have any questions so far, or are you all okay with it?
No questions.
No far. Okay. So are they? Am I talking too fast? Or the point that I'm trying to say is, glaucoma is an aging disease, and open-angle glaucoma is the most common cause of glaucoma in the world. But in Asia, 2/3 of our glaucomas are actually angle closure, and angle closure glaucomas can cause more blindness. So that's the take-home point. Okay. So now we're going to go to a bit about basics of what is glaucoma. So it's actually a chronic neurodegenerative disease, and it's characterized by loss of retinal ganglion cells, resulting in distinct changes in the optic nerve head and retinal nerve fiber layer. Do you all know what I'm saying? The other term for it is it's a progressive neurodegenerative optic neuropathy with characteristic structural changes and functional visual field changes. So here it means that if you see this first picture, the optic disc looks like is like a donut. So you want to have more red and less hole. Like you want the hole of the donut to be small. But in advanced glaucoma, the donut, the size of the hole is very large, and the red, which is the flesh of your donut, is much less. So this is advanced glaucoma. In this stage, this is no glaucoma, this is mild glaucoma, this is moderate glaucoma. So glaucoma generally means it's a progressive optic neuropathy. It's optic neuropathy means it affects the optic nerve. And what is the optic nerve? It is the nerve or the cable that connects your eye to your brain. And the thing is, we use this word neurodegenerative. That means once it gets damaged, it cannot get better. You need to keep to make sure that it doesn't get worse. So again, an example of what progressive optic neuropathy means. So say that this patient was seen in 1988, and you will say, look at the cup to disc ratio. This would be about 0.6, 0.7. But over the years, there's an increase in the size of the cup to disc. So this patient could most probably has glaucoma. So it's very important to take fundus photographs or to document our optic nerve findings very well. So glaucoma is not just one disease, but it's a group of eye diseases that damages the optic nerve. The optic nerve is a bundle of nerve fibers that carry information from the eye to the brain, and it can start without warning. So sometimes there's no signs, and usually sometimes in open angle glaucomas, the patients really come very late, and they'll come with history of knocking into things, or they're missing things, or their family members say that, there's actually a pen on the table, but the patient is actually asking for where the pen is, or when they're trying to pour hot water or something from a kettle into a mug, they're going to miss it. So most people will think, oh, it's just a reflex because they're older, but actually it could be a visual field defect. So because of that, the patients can't actually see the cup that's there. So more than 60 million people in the world have glaucoma, and it's that's what I want to say. Okay. So now going to the next slide. What are the risk factors of glaucoma? So high intraocular pressure is a major risk factor, but there's no mention of the specific number. So always people will ask, what is the normal pressure? I will talk about IOP in the next few slides because we have a little bit about it. So I will talk about it then. High intraocular pressure is a strong risk factor. Aging, with age, it increases by about 25% per decade. So per decade means every 10 years of our life. So say from the 50 to 60, 60 to 70, it keeps increasing by 25%, and that's a large amount. Positive family history of glaucoma. also is a major risk factor, strong risk factor. Race, African American for open angle, and among East Asians, it's angle closure. If you have a suspicious optic nerve appearance, which I've showed you in the previous photograph, whether there's asymmetry or whether the vertical to horizontal cup to disc ratio, that is a strong risk factor too. And if the central corneal thickness is thin, then it's also a high risk factor. Now, the possible risk factors which could be present in most of us, if you're high myope, Huda, you've been starting to wear glasses from what age?
30.
So your power of your glass is minus
275.
So you're a myope. So
Yeah.
myopia means you're nearsighted. You've been starting to wear glasses from a young age, and it's always a minus powered glass. Hyperopia, on the other hand, is a plus glass. That means we can't see near. We have a problem with near vision. Diabetes, hypertension, they are all vascular problems. They are all systemic problems. And as you know, in Malaysia, we have a high incidence of diabetes. And that's why that is one of the most high risk. Diabetic retinopathy is one of the major causes of blindness in Malaysia. So diabetes, hypertension, previous eye injury or eye surgery are possible risk factors. The other risk factors are patients who are on steroid use. This steroid use can be oral, topical, inhalers, anything. So if you have asthma and you're on chronic use of steroids, inhalers, it's also a history of steroid. Migraine, headaches, peripheral vasospasm. This is usually more common in females and in the age group of between 20 to 40, in the younger age group like Huda, and not in my age group because I'm the older age group. So then you have sleep-related disorders like sleep apnea is also a cause, and males maybe in this time.
How does using topical will increase the risk factor, because it's in the eye, right?
Steroid.
Yeah.
The reason is because steroids will actually affect the trabecular meshwork. So it kind of because of that, it will actually cause rise in intraocular pressure, and that's one of the major causes of secondary glaucomas. Steroid. So there are a lot of young females, Malays females. They have a lot of them have SLE, systemic lupus, rheumatoid arthritis, or any of those conditions. So they all have to actually see an eye doctor, and especially to assess for glaucoma. So are we okay with the risk factors, guys?
Guys, if you have questions, just feel free to ask here.
You can stop me anytime. So now this is the American Academy of Ophthalmology, and this is the recommendation for glaucoma screening. So as you can see, if you're below 40, without any risk factors, they should get their eyes checked about every 5 to 10 years. But if they have risk factors, so in the younger age group, it's usually refractive errors like myopia and things like that, or if the patients had a trauma, or if they have steroid use, then it becomes every 1 to 2 years. From the age of 40 to 54, without risk factors is every 2 years, but with risk factors is 1 to 3 years, 1 to 2 years. And after the age of 54, it's every 2 years without risk factors, every 1 to 2 years onwards with people with risk factors. More than 65 years old, it gets more and more common. So you have to assess these patients, and you have to keep them on your follow-up, and patients need to be told about going for eye screening. So a lot of people, all of you, most of y'all, because y'all are in corporate clients, so y'all will be given to go for your yearly screening, but it's general health. But actually you should also have an eye screening done ever so often. So with all the risk factors that I mentioned, that's why it's important. So why is screening important in glaucoma? Because it's the leading cause of irreversible blindness. And because we have an aging population, middle age and older, we don't want them to end up having functional visual impairment. So it's very important for us to screen them and pick them up early. we cannot cure glaucoma, but we can control it to minimize the progression of the disease. And by doing that, we can improve the quality of life and reduce the cost. So even early glaucoma can have significant loss of visual function. So the worrisome thing is most of the time there's no noticeable symptoms in the early stage, and vision loss progresses at such a gradual rate that people usually are unaware of it. So the main risk factors for glaucoma blindness is late presentation with advanced disease. The usual way I like to tell is like if you have a cancer of the breast for women, right? And if your grandparent, if your grandmother or your mother was picked up at stage 4 and your risk increases of cancer of the breast, you don't want to be picked up at stage 4. You should try to pick up at a pre-malignant or in an early stage. So that is why glaucoma management is also like that. So we like to screen it much earlier. No questions so far? Right. Am I going too fast? Or are you fine? Okay. So now what are the 5 things that we should check before making a diagnosis of glaucoma? We have to check the eye pressure. We have to look and document the shape and color of the optic nerve, which is the structure. We have to have a complete visual field assessment, which is the functional test. We have to distinguish between open angle and closed angle by doing a gonioscopy examination. And we have to measure the thickness of the cornea because that is one of the strong risk factors if you have a thin cornea. Okay, so there are a lot of things that we need to do. So now I will talk a little bit about the types of glaucoma. When we were talking about prevalence, I was using the word open angle and angle closure. Am I on video? Yeah. Okay. Yeah, hi guys. So this, say for example, is the eye. Can you see actually here there would be there's something missing, that's the cornea. So this is actually the angle structure. It's called like when we describe it to our patients, we say that longkang, the drainage system. And actually what is the drainage system? It's very important for us to differentiate between open angle and angle closure. Doesn't matter, sorry. Okay, so it's important for us to distinguish between open angle and closed angle. And how do we do that? I'm going to give you so open angle and angle closure, the older we get, the higher chances of getting glaucoma. May be open angle or angle closure. But angle closure is more common among females. Remember, I showed you a slide about Asians, females, and aging. So females are more predisposed. Patients with East Asian origin, Chinese, Indians, we tend to have angle closure more common. And the anterior chamber, which is the space between the cornea and the iris, or the drainage system, is much shallower. You may have elevated intraocular pressure. That could be family history. And I put here about diastolic perfusion. It's actually about to do with blood pressure. And open angles are more common among the myopics, and angle closure is more common among the hypermetropic. Hypermetropic means your eyeball is smaller, shorter, so there's more crowding with age. This doesn't go. Okay. So, like you know, open angle is usually asymptomatic, but acute angle closure, on the other hand, is not. It's actually one of the major causes of a painful red eye, and it's associated with periocular pain, headaches, nausea, vomiting, rapidly progressive blurring of vision, and sometimes patients will see halos of light. What are the signs? Patients will have ciliary flush. Can you see that this picture, there's a lot of redness in the eye? Sorry. And the redness is usually near where the cornea ends and the sclera starts. So this is the limbus in the arrow, and that's called a ciliary flush. there will be corneal haziness because the cornea becomes very hazy because the pressure is very high and the pump that maintains the corneal clarity is not functioning very well. So there is swelling, and that's called edema. The pupil would be mid-dilated. There will be the AC anterior chamber is very, very shallow, and you can have peripheral iridocorneal contact. You can have glaucoma fleckens here. This is actually anterior lens becomes opacified. So if you see this in some patient, then they could have had an acute angle closure in the past. And these patients usually present with very high intraocular pressure, and that is why they are in severe pain. So in these conditions, we will have to, it's an emergency, we will have to bring down the eye pressure very fast, and then we will have to do other procedures. So if we don't bring down the pressure very fast or quickly, then there will be permanent damage to the optic nerve and nothing can be done about it after that. So, you know, it's always a question about, remember when I said just now, glaucoma is a progressive neurodegenerative condition with characteristic structural and functional loss. It is found that it's always whether it's, you know, it's like a chicken and egg story, whether structure is first or function is first or function is first and structure. So there are lots and lots of studies and they actually found that it's postulated that structural loss precedes functional loss. So it's very important for us to look at the disc in all our patients because careful evaluation of the optic nerve continues to be essential for diagnosis of glaucoma. So here now, I'm just going to show you lots of optic nerve pictures, just a quick one, just to say that there are many different, just like human beings, we all come in different sizes and shapes and colors, so does the optic nerve. So picking up an optic nerve damage or looking at it and saying that this is probably glaucoma in certain cases is not so simple. So that's why we will have to take fundus photographs and we will have to monitor them over the years, like what I had showed you in one of the serial photos just now. And then we will have to look at the optic nerve and optic disc changes. So this is like looking at a cup that is small, and this is the disc. But here, this patient, the cup has increased. So this could be, let's assume it's the same patient. So this would be a progression, okay? So then another photograph, there are many, many different types of photographs. Sometimes the disc is, the nerve itself is a big nerve. You know, like some of us are 5'5", and some of us have size 7 shoes, and some of us have size 5 shoes. Who's normal and who's abnormal? That's genetic. We all, you know, we either come from a family of big feet or we come from a family of small feet. But if the size of the shoe keeps increasing once we have stopped growing, then it becomes progressive. That's how we look at glaucoma. So that's about the optic nerve and that's about the structure. I'm going to touch a little bit about what is considered normal eye pressure. Remember just now we were talking about strong risk factors, and one of the things I said was high intraocular pressure. The thing about what is high, there's no number, and what is low, there's also no number. The thing is about 90% of the people will have a pressure that ranges from 10 to 21 millimeters of mercury. 90% of patients, of the population, will have a pressure between 10 to 21. I'm saying that again. And the average eye pressure is about 15 millimeters. This is in this normal group. So now let's say all of us, about how many of us are attending this talk? About 25. So about 25 of us are attending this talk right now. And some of you may be very stressed. Some of you the aircon might be very cold. The aircon might be very hot. It's 2 o'clock in the afternoon. You just had lunch, so you might be sleepy. So they're different, each of us could be in a different state. So just like that, it's the eye pressure. So sometimes you can have a pressure about 15 and you can have glaucoma. And sometimes you can have a pressure of 25 and you still may not have glaucoma. So we cannot diagnose glaucoma based on the intraocular pressure as a number. Okay. But the only thing that we can treat in terms of glaucoma is the intraocular pressure. So once we start medication or when we do surgery, then we will look at the baseline eye pressure and we will compare it with post-treatment. Are you all with me? So that's why progression of glaucoma is actually a very, very big topic. And I put it in bracket in the beginning of this talk because talking about visual fields, talking about eye pressure, it's a lot. So saying that, there are many, many ways.
Dr. Thaya, sorry
Yes,
for
please.
interrupting.
No, please. Yeah, I love that. Yeah.
Just clarify. So you are saying
Yes.
the measurement of any successful treatment for glaucoma is the IOP?
To monitor patients with glaucoma, it is the intraocular pressure will be one of our parameters.
Okay.
Okay. Now, I'm saying that, but I need to tell you, like, have you ever gone for your blood pressure checkup?
Yeah.
So when you're stressed out, your blood pressure could be pretty high. And then if you sit down and wait for half an hour or 1 hour later, the blood pressure can come down.
Mine is still high.
Okay, then you're hypertensive, I suppose. Okay, so just like that, the eye pressure and the blood pressure have ups and downs. They actually have fluctuations. And the problem with the way that we are taking intraocular pressure in our clinics, it's at 10 o'clock in the morning. It's a snapshot in time. It doesn't really reflect the intraocular pressure throughout the day. So say, for example, you have high blood pressure and the doctor is worried about your heart or something like that. They will give you a BP monitoring, they'll put you on a halter for 24 hours or 48 hours. And that is actually to look at the highest blood pressure and the lowest blood pressure and things like that.
Okay.
And we also need to do the same thing for intraocular pressure in a way. But most people are just taking, like this particular photograph, they're taking it as a snapshot in time. So intraocular pressure is actually a complex thing, but it's just like your indicator of your company, the indicator of success or indicator of whether you're a good salesperson is the number of bottles of medications that you sell, something. But it doesn't actually translate to every other facet of your development as a person. You get what I mean?
Yes, very clearly.
Yes, absolutely. So the thing about glaucoma is a lot of things. It's like I'm just trying to give you a very broad overview, but I don't want you to skew so much. I'm trying to make it give you what is standard and what is the possibilities. So there's many, many ways to measure the eye pressure. We have, this is our gold standard. This is called a Goldman applanation. And that's usually you have to have it in all glaucoma eye clinics. And I have it here. And there are other ways. You can check your eye pressure using air puff, and all kinds of other things, tonopen. There are loads and loads of different gadgets out there, but your gold standard is still a GAT. This is the gold standard, and I'm comparing it with air puff, which they have in, when you go to optometrists to check for glasses, you'll sit on a machine and there will be a puff of air that hits you. It kind of overestimates IOP by sometimes more than 20 millimeters. The good thing about this air puff is it can be done anywhere. You don't need anesthesia. It's quick and it's usually used very well in children and uncooperative patients. But on the other hand, the Goldman, you need to have a slit lamp to use it. So those are the things that is the downside of GAT, but it's the gold standard. You need an expertise. You need to use local anesthesia. You need to know your pachymetry, which is the central corneal thickness. usage. It's widely used in all our practices, and more so if you have glaucoma, if you are managing glaucoma patients. So our gold standard is still Goldman applanation. So I'm coming to okay, so now the thing is, like, remember we were talking about whether you want to pick up cancer when it's stage 4 or whether you want to pick it up at stage 1 or pre-cancer. So that's the kind of management that we want to do. We want to pick up pre-perimetric glaucomas. And pre-perimetric glaucoma means looking at the optic nerve, and the optic nerve looks very suspicious, but there isn't any signs of functional loss yet. Visual field is not impaired. So that's when you want to try to pick it up if possible. So early detection is very important, and that's through regular and complete eye examination. Why are there so many diagnostic exams? Usually the patients will come and ask, you know, they always are very suspicious when they come to any doctor and we do a lot of tests. They think, why do I need to do so many tests in order? My eye pressure is normal, within the normal range. They'll ask you what's normal range, and then you'll say the usual 90% is 10 to 21. So if it's normal, then why do I need to do it? Why do I need to do that? Because in glaucoma, we have to find a correlation between structure and function. That is the key. That is one, to find a correlation between structure and function. Number 2, we have to show progression. So you could be a shoe size 5 and I could be a shoe size 7, but I could be genetically coming from a size 7. I could come genetically from a big, cup disc kind of thing. So that is why all these are important. So recap, early detection is complicated. It's very easy when you want to pick up a cancer in stage 4, right? It's obvious. You either have a large mass or a tumor that's grown so much. But if you want to pick up in a pre-malignant stage, it's like looking for a needle in a haystack. And that's what early glaucoma is all about, and pre-perimetric glaucoma is all about. Abnormal does not equate to disease, but we need to know whether this abnormal is physiological or pathological. So we have to be also very aware of underestimating or overestimating. We need to combine structure and function assessment. And like I said just now to your question, we need to look at IOP more than a snapshot. Just like your blood pressure, we need to look at it in much more detail. And this is maybe not for you all, but if for our doctors, we would say maybe sometimes you'll have to change your program of your visual field testing to look for early changes, and we need to individualize our management for all patients because it's not one size fits all. Sorry, I'm going off. Okay, so now it's important. In the Western country, a lot of patients are overdiagnosed to have glaucoma because lots of Western white population, they would have access to doctors. They are living in a first world country, so a lot of them might be overdiagnosed. On the other hand, in Asian countries, there's a risk of underdiagnosis and undertreatment. So there is always a risk of overdiagnosis and overtreatment. This is from actually the latest APGC that was held in 2021 in Malaysia. And this is the European Glaucoma Society guidelines, the latest. So actually I took this as a snapshot, but I put it here for you all to understand. And now, why do we need to treat glaucoma? So I've given you a prevalence of glaucoma. What is the basics of a little bit about glaucoma? What are the types of glaucoma? What are the risk factors for glaucoma? What is glaucoma per se? And now we're going to talk a little bit about why do we need to treat. So the reason why we need to treat is we need to preserve the visual function adequate to the individual's needs with minimal or no side effects for the expected lifetime of the patient without any disruption to his or her normal activities at a reasonable cost. And that's a tough thing to do, okay? So, so what are the factors that we need to consider before glaucoma? You know, when we want to consider, we need to consider the initial intraocular pressure. So we need to know the baseline pressure. What is the life expectancy of the patient? The ethnicity. So if you're an African American in America, your risk of going blind is much higher than a white Caucasian. And if you're an Indian or Chinese, your risk of going blind from glaucoma is going to be higher because you're going to be more predisposed to angle closure. And at which stage of the optic nerve damage were we picked up? So if you had early damage compared to a person with late damage, our glaucoma management is going to be very different. And also compliance. So you can prescribe all the medications in the world, and if the patients don't put the drop, it's no point. You've lost the battle. So this is the first part, and I've completed the prevalence of glaucoma, glaucoma disease, or the basics of glaucoma, but I'm not really going to talk about progression because, as you can see, it's already, it's simple, but it's very complicated too. So at the moment, do we have any questions? Thaya.
Guys, any question from the floor?
Dr. Thaya,
Yes.
I'm just quite interested to know.
Yes. What's your name? Sorry.
Sorry, Mahin here.
Hi, Mahin. I'm Thaya. Yes, Mahin. Tell me.
Yeah. So I just want to know, a lot of patients come to see you in your practice. I just want to know at what stage are they initially diagnosed first of having glaucoma?
Okay, Mahin. Actually, I was just telling Huda just now. I've done 28 years of government service. I just retired. So now I'm doing private. So sadly, in government hospitals, a lot of cases that are referred to us because we are a tertiary center. I was in Hospital Kuala Lumpur, was a senior consultant there. So a lot of the cases that come to us are usually in advanced glaucomas.
I can imagine.
Yes, that's right. So, but in private, some people are coming because now they are more aware of glaucoma and the awareness needs to be created. So if there's family history of glaucoma, then they tend to come earlier. So, but still in Malaysia, we are still seeing a larger number of percentage of patients are coming in the advanced glaucoma group.
So you would have seen a lot of patients who actually gone blind.
Yes.
And there was nothing much you can do to help them.
Yes, sadly. Maybe they've gone blind in one eye. So we have to try to maintain the visual function in the other eye. So the whole thing is actually, remember I had a slide about the visual function. So you actually, remember there's a graph. You don't want the graph to go down too much. So that's where we actually try to pick up our patients and try to avoid that kind of thing that's happening. So it's always, we are trying to maintain the functional capacity, for the remainder of their life. So as long as they can move around and they can put their drops, they kind of know when it's daytime, nighttime, things like that, and they can manage, that's very good. Actually, we have a large percentage of patients also who come with congenital glaucoma. GHKL was one of the centers where we had pediatric ophthalmology, and the late Dr. Joseph used to do a lot of glaucoma cases, congenital glaucomas and things like that. So glaucoma doesn't see race, doesn't see age. So I'm talking in this particular lecture that I'm giving, I'm mainly talking about glaucoma related to older age group, adults. But you also have a small group of patients with congenital glaucomas.
So what's the cause of the congenital?
It's genetic. So there will be an abnormality at the drainage angle. Remember, we were talking about open and closed. This babies sometimes are born with the longkang itself being abnormal since birth. So they are born with ophthalmus. They present with tearing. Their eyes look very beautiful because the whole cornea is very, very very big. It's megalocornea like that. So there are many, many types of glaucoma.
So
Yes.
that means if the children were, if a child is diagnosed with this congenital glaucoma, do they need to be on eye drop for the whole life, or is there a chance that it can be treated?
For children with glaucoma, usually the first line of treatment is surgery. It's not eye drops, because the underlying problem is like a block in the drainage system. So you have to do surgery to unblock it. Then over the years, they may need eye drops as well. But the first line for children, babies or young children is surgery. Whereas in adult glaucoma, it's mainly, you can try medications first. So did I answer your question, Mahin? I'm sorry.
Yes, you did. Thanks, doctor.
Okay. So are we okay now to go to the second part?
Yes.
Dr. Thaya.
Yes.
I'm Audrey.
Yes, Audrey. Hi. Can I just, while I'm talking, can I just have a quick sip of water? I'm listening to you, dear.
Yeah, doctor, I just want to check with you. Just now you showed us a slide for what they call that, for the duration or how frequent by ages that we should actually do our glaucoma screening.
Yes.
Okay, for 80 and above is every 6 months, right?
80
Or 60 and above? Your previous slide.
65 and above. Can you see the slide right now? Yeah, 65 and above. If you have no risk factors, means no diabetes, no vascular problems, no myopia, no hyperopia, no nothing, then it's every 1 to 2 years. But if you do have any one of those, you need to see a doctor every 6 months to 1 year.
Okay, my question is for
Yes.
those patients that have glaucoma, I mean, for those that above 65 years, and then they have undergo the surgery.
Okay.
What is the duration? I mean, how frequent?
Audrey? Okay, very good. This particular slide is for glaucoma screening. This is not for patients who are already diagnosed to have glaucoma. Once you're diagnosed to have glaucoma, the screening is not fixed. There's no screening. It's no more screening. It's considered management of glaucoma. So now, depending on a lot of factors, remember I put a slide just now. What are the conditions that what are the things that you look at? So if the patient is young, 65, and the extent of the damage is very extensive, you may want to see this patient every 1 month, 2 months, 3 months, depending. If this is the only eye of the patient, your review with the patient will be much sooner. So, but if the patient is all stable, both eyes are still okay, the nerve damage is not very extensive, then the doctor might say every 6 months, 3 months, depending. So even though the person had a surgery done for glaucoma, the surgery can fail over time and the patient's pressure can start climbing. So glaucoma surgery is not like cataract surgery. Cataract surgery is you take out the lens, you put in an artificial lens, you're already done. But in glaucoma, if you're doing a surgery like a trabeculectomy or a GDD or anything, I'll talk later, these surgeries can fail over time. So these patients will still require constant follow-up. Just like, for example, right, if you have cancer of the breast, I keep going to cancer of the breast because I guess because we're female and it's easy for us to understand. So say I was picked up at stage 3 or stage 4 and I've done a mastectomy. And I've also done chemotherapy and radiotherapy. Does it mean I'm free of cancer? Audrey? No.
No.
Yes, because you can still develop, you can get metastasis, so you need to still be on follow-up. So it all depends on which stage, how bad it was in the beginning, and all those kind of things. So once you're diagnosed to have glaucoma, it will depend on how advanced your glaucoma is, your life expectancy, your nerve damage, the condition of the other eye. So if a person has lost one eye because of glaucoma or trauma or diabetic retinopathy or anything, and now this is the only eye that is left, we will see them more frequent. Is that okay, Audrey? Is that okay answer?
Okay, thank you, doctor. But doctor, I have one extra question. Sorry.
Please go ahead.
I want to ask for a patient who actually has cataracts and also glaucoma together. If he has to do a surgery, can it be concurrently? I mean, one-off surgery to settle two problems?
Can, but there are lots of studies that are showing that doing a combined surgery is not as successful as doing a stage surgery. So it's like, how shall I say? Now I have a roof problem in my house, and I also have a problem with one of the walls. How would you want to go, Audrey? Do you want to do both one shot, or do you want to settle the roof first and then settle the wall? Something like that. So maybe in sometimes we will say, if it's an angle closure kind of glaucoma, we might want to settle the lens first, take out the cataract, and then later maybe deal with the glaucoma. Because sometimes you may be able to get away with drops, medication. Sometimes you might need more complicated surgical intervention. So it's actually, we have to individualize our treatment for each patient and no one size fits all. And some people do both surgeries together because they want to save time or whatever. But for me, glaucoma management is about the long haul. It's not about the 100-meter race, it's about the marathon. So Mahin, coming back to your question, there have been patients who have had the other end of the spectrum in their management. They've had tubes put into their eye when they're 20 years old.
Wow.
And now they're coming at 22 with on 4 drops. What do you do now? You know what I'm trying to say? So you've already gone and you've gone with the other end of the spectrum for your management for these patients. So these doctors thought that, okay, GDD or a tube is going to be great, but within a year or two, the tube has failed.
They need to be on the eye drop.
They've been on the eye drop, and now their pressures are very high, or needs to be dealt with. So now what you're going to do? You're going to put another tube? Yeah, you could, but the problem is the failure rate with the second tube or subsequent surgery, the risk of failure becomes higher and higher. So if you're doing a surgery and if you're doing it, you're planning your surgery. So if it's like renovating your house, you decide how you want to do, because sometimes you may want to fix the roof first. Because if you fix the roof, then you're actually fixing the floor, you're fixing, water won't get onto your floor and damage your floor, you won't damage the wall. But if you go and fix the wall first and without fixing the roof, it's still going to be a problem. So it's not so simple. So you really have to look at all these parameters on the slides, the life expectancy, the extent of the nerve damage, and everything as a whole. Then only you'll be able to manage your glaucoma better. Okay, so what time is it now? 3 o'clock. Okay, so it's been 1 hour right now. Do you all want to take a break, or are you all okay to continue? Are we okay, guys, to continue?
Maybe 3 minutes nature break.
Okay, sure, go ahead. Great. See you in.
We take 5 minutes.
We take 5 minutes, okay? Is it clear, Uda?
Yeah, it's clear. No, I know it's not that easy as it is. It's just like, IOP and then.
It's like making a cake. You need all the components to be betul. It's
Yeah,
not
if one is more than the other, then your cake won't rise up.
exactly. Yeah, but people make it look like it's just about eye pressure. But eye pressure is so subjective. Just like blood pressure is so subjective.
Yeah.
Oh my God, I'm not on mute either. Oh my goodness.
Okay. So the second part, more on the treatment for glaucoma, the different eye drops. So Dr. Thaya will touch on this. Okay, so we'll continue for the second part.
Okay, all of y'all had some break. Better have a cup of coffee. It's going to be such a drag. Are y'all finding this informative enough? I hope. So now I'm going to actually talk about treatment. And before we go to what you guys want about your eye drops, I'm going to give you an overview first, and then we will go to eye drops, and then you tell me, okay? So this is really a pretty informal session. So again, the goal of treatment is to maintain the visual function and related quality of life at a sustainable cost. This is world over, European Glaucoma Society guidelines, everybody's guidelines. Now, the only thing, every study that has been landmark studies talk about reduction of pressure. So by reducing the pressure by 10 to 13%, 19%, 20%, you can try to preserve the visual function. They talk in terms of percentage, but nobody tells you actually which is the ideal number. Sometimes too low a pressure also can cause problems. Too high a pressure also causes problems, that you know, but you don't know about the too low pressure. So we'll just to let you know. So now what are the current option treatments for glaucoma? Medical, laser, and surgical. There are some studies based on this CGIC study. There's no difference between initial medical treatment versus surgical therapy in visual preservation. But patients preferred medical therapy because it's less troublesome. So in surgery, I'm going to put it as non-invasive and invasive. Under non-invasive, we talk about lasers. So in open angles, like we had open angle glaucoma, we are talking about different kinds of lasers. In angle closure, there are different kinds of lasers. And in both, there are some of these lasers that I've mentioned here. So you're with me, yeah? So the uses of lasers in glaucoma is mainly for diagnostic and also for therapeutic. So in diagnostic, we use it to measure the thickness of the retina. So the retina is actually this red color thing here, and it's actually got 10 layers in it. But in glaucoma, we are only interested in one layer, and it's called the retinal nerve fiber layer. So I usually tell the patients it's like kue lapis. So you actually want to make sure that all the layers are about the same thickness and things like that. So in OCT is what you're looking at, the thickness of the retinal nerve fiber layer. Now, the uses of laser in glaucoma is to help to relieve the pupillary block. All this is acute angle closure. Remember, I showed you a slide about acute angle closure, how we need to reduce the eye pressure. We also need to do a laser peripheral iridotomy, things like that. So this is for peripheral iridotomy. We make a little hole in the iris so that the fluid can go, give you an alternate flow of the fluid to come out of the eye. I'm not going to go into the details, but I'm just going to give you an overview. Then another thing is you can relieve appositional closure by doing argon laser peripheral iridoplasty. All this is usually done in narrow angles. Okay. Then if you want to reduce, the thing about intraocular pressure is it's based on production and aqueous outflow and aqueous inflow production. So but this cyclodiode actually knocks out the factory that produces the fluid. So it knocks out the ciliary body, which produces the aqueous. Aqueous is actually the fluid that is a nourishing fluid that comes from the back surface of the iris, comes to the front surface of the iris. So by doing that, it will also reduce pressure. Then there's argon laser, trabeculoplasty, and SLT. So all these are different ways of also reducing eye pressure. And this can usually be done in open angle glaucomas, not in angle closure, more for open angle glaucomas. So when I went to visit Robert Weinreb, I think if I'm not mistaken, in San Diego, his slit lamp, like in my room, we have a slit lamp here, and we just look at the patient on the slit lamp, and then we use our instrument just to check the pressure. But in Weinreb's, it's also associated with another laser machine, and that's called the SLT. So if the person is diagnosed to have open angle, the first thing he does is he does laser. So that's why sometimes, you could do that. So there was a paper, a large a series between lasers or drugs. I'm putting this because y'all are in Pharma Niaga, so I wanted to tell you about drugs. I know we will get there, but there's also a role of lasers in glaucoma management. And as you can see, the lasers in glaucoma are a lot. Different kinds of lasers for different conditions, different reasons, different timing. So then you also have minimally, so under surgery, we are now going to the invasive group, where we have, everybody is talking about this minimally invasive glaucoma surgery, which is called MIGS. And then you have invasive. trabeculectomy still remains the gold standard. Then you have drainage device, and you have even Zen implants. So this is also taken from the latest APGC this year, and they actually divided mix into ab interno and ab externo, whether it's subconjunctiva, whether it involves the drainage system, or whether it involves the choroid. So minimally invasive glaucoma surgery will be eye stents. I'm sure you've heard of all this. This is actually putting a little tube into the trabecular meshwork and thus reduce the pressure. Then you also have loads of little, stents, or supra, like a thread that you can put and all that stuff. Then you have devices that enhance subconjunctival glaucoma surgery, which will be your glaucoma drainage devices. And then you also have your Zens here, which some of you would have heard about. Zen is not considered minimally invasive according to the latest APGC, because it forms a bleb. That means it collects fluid. So then it's not considered as minimally invasive. It comes under the trabeculectomy part. So although there are so many new techniques, trabeculectomy is still the gold standard in reducing intraocular pressure, getting it very low, in the sense that you can have a 40 to 50% reduction in intraocular pressure compared to baseline. So that's why trabeculectomy still is the most efficacious procedure. But what is the problem with it? In the past, trabeculectomy, just like any other glaucoma surgery, has got its advantages. It can reduce pressure very much, but it also can lower the pressure too much and until it causes another set of problems. So imagine your eye to be a ball, and you have you want to make a little hole in the ball, but you don't want to make too big a hole. So that's what trabeculectomies are about. So so now they actually have, the problem with surgery is all these are problems that can be associated with glaucoma surgeries. So that's why we don't go straight away to surgeries in most instances. So just to put this for you, but no need to worry about it. So for a surgeon who does all these surgeries, you might not be able to sleep at night because there's so many complications of glaucoma surgery: hypotony, choroidal maculopathy, AC very shallow, the lens becomes, there's bleeding, or also the fluid leaks out of the eye, and it can cause infection, and you can lose your eye as well. So the best surgery, what do we want? This is from Sir Penkor, who is actually a Malaysian, and he's in England. And what he wants, the ideal surgery is, it has to be fast, it has to be easy, it has to be effective, no complications, with quick recovery and no post-op manipulation. So his ideal surgery would be something that gives him it's a 10-minute procedure, gives him 10 millimeters of intraocular pressure, and it can work for 10 years. So that's his 10-10-10 of Sir Penkor. And that's what everybody is trying to aim to, but we are nowhere near there yet. So now we've touched a bit on surgery. We've touched on lasers, which are non-invasive, and we touched on surgery, which is invasive. And now we're going to go to what you guys are all waiting for, the medical treatment of glaucoma. So kind of saved the best for last, I suppose. So it's the thing about medical treatment, it has the best safety profile compared to surgical intervention. Surgical intervention, lasers are not, they also have pretty good safety profile, minimally inconvenient and also affordable. But whereas, all those MIGs and trabeculectomies and GDDs are not, they are very invasive. So we have to be very careful about it. So now these are the evolution of medical drops. Actually, as early as 1800s, pilocarpine came into being. And actually after that, it followed by epinephrine. So from the 1800s, till the 1992, there was not many drugs. So according to Kuldev Singh, who's a famous ophthalmologist in America, explosion of new drugs actually happened in the 1990 to 2000 something kind of time. And this is this explosion is compared to all the preceding over the last 100 years, there's not many drugs. And suddenly you have a bang, you have loads of drugs. So latanoprost came in 1996. 1994, dozolamide came, which is a true shot like that. So now, are you all okay, guys? Yeah. So now when we're talking about the drugs, prostaglandin analogs, which you all are very familiar with, gives us an IOP lowering of 25 to 35% as a single drug. Beta blocker, which is like timolol, gives us a 20 to 25%. All this is a single user, single drug. Carbonic anhydrase, CAI, is about 20%, alpha and adrenergic about 18 to 25%. So this is a little bit. So now you have loads of drugs since 1996, 3 new classes, which was topical carbonic anhydrase, prostaglandin analogs, and alpha agonists. And all this is the ability to achieve sustained reduction in intraocular pressure and hopefully delay the need for surgery. So this is till about 2014. Now, since 2014, there's another class of drugs which has come out, which is Rho kinase inhibitors, nitric oxide donators, prostaglandin EP2 agonist, bimetoprost SR implants, and this adenosine is not here yet, but this is what is in the pipeline. So I'm just going to now touch a bit about what is our first line medication. The gold standard and what is advised all over the world is topical prostaglandin analogs or a beta blocker. Second line is alpha agonist or carbonic anhydrase. And then after that, it's like a combination of all these drugs. So what is the aim of using all these drugs? You want to lower the IOP. You want to probably increase the outflow facility. And you also want the drug to be neuroprotective. So that's the key right now. So now prostaglandin, just an overview. Do you all want all this? Yeah. So this prostaglandin is just a once a day dosing. Usually we prefer to use it diurnal at night or nocturnal to reduce the IOP. Prostaglandin is one of the only drugs that doesn't have any systemic side effects. It doesn't cause any problem to the patient's well-being generally. And it reduces the pressure by about 30 to 35%. And how does it do it? It increases the unconventional outflow, which is the uveous scleral outflow pathway.
Is the reason why it's given at night compared to during the day?
Okay. Did you all hear Huda? She asked whether it was given, why would you prefer to give it at night and not in the day? The reason is, remember earlier when Naren, I think, talked about blood pressure. When we sleep at night, the intraocular pressure actually is the highest between 12 midnight to 6 a.m. in the morning. So if you give the medication at night, the prostaglandin takes about 2 to 3 hours to work. So say you put it at 10 o'clock at night, it will start working about 1 a.m. And so you'll get the best reduction in pressure at that time. So that's why we prefer to give it at night. And if you give it, it has to be a fixed time. So say it's 10 p.m., it has to be 10 p.m. every night. If it's 11 p.m., it's 11 p.m. Half an hour earlier or later is fine. Sorry. You'll have to worry about, just like any topical anti-glaucoma, you will have conjunctival hyperemia. But in prostaglandin, you will have longer eyelashes, and sometimes you will have periorbital pigmentation, And now they have this, I've forgotten the name right now, it comes to me. You will have a fat atrophy of the eye. So it's called PAP, periorbital fat atrophy or something like that. So that's one of the things about prostaglandin. So all these things, these are the FDA approved ones as of January 2007. So then you have beta blockers. It's at one time it was the drug of choice before prostaglandins came into the to the picture. And beta blockers decrease the intraocular pressure by actually reducing the aqueous production. It stops the factory from producing the aqueous, whereas prostaglandins work by increasing the outflow. So when we talk about glaucoma medications, we actually talk about drugs that suppress aqueous production or drugs that increase aqueous outflow, just like in some of the laser management as well. Here, as a single drug, it reduces the pressure by 20 to 25% now. But the problem with beta blockers is it has lots of systemic side effects. So if a person who is asthmatic or if the person has already a heart problem, beta blockers are kind of contraindicated. It increases the risk of falls in the elderly, and in young men, it also can cause impotence. So using a beta blocker, we have to be very careful. Alpha adrenergics, on the other hand, they have two functions. They inhibit aqueous production, and over time, they will increase uveal scleral outflow. But the problem with this drug with most patients is they have a very red eye and sometimes have allergy symptoms like itchiness and all those things. So usually we tell these patients that these symptoms will reduce over time. So initially for the first 2 weeks, it'll be very, very bad. Then after that, they'll get used to it. And then there will be still redness, but it won't be so bad. So these are alpha adrenergics. So if you use alpha adrenergics and carbonic anhydrase, they are used as a single drug. It's 3 times a day dosing. When I say it's a single drug, that means if you're using it as only medication. Beta blocker is 2 times a day. But if you use timolol XC, then it's once a day dosing, but it's in the morning because the efficacy of the drug and the way it works is different from prostaglandin. So the choice of us choosing 2 times a day or 3 times a day, or whether it's morning or night, it's all got to do with the action of the drug. Carbonic anhydrase, on the other hand, reduce pressure by 15 to 25%. If it's a single drug, it's 3 times a day dosing, just like alpha agonist. But if it's using it as in a combination together with prostaglandin as a second line or third line, then we can use it 2 times a day. Okay, are you all with me? Carbonic anhydrase also works on reducing aqueous production. Okay, so just like beta blocker. The problem with this is a systemic carbonic anhydrase, which is called Diamox. So in patients who have acute angle closure, who had very high pressure or cornea is very hazy, patient is in pain, we give this straight away, 500 milligrams stat dose and stuff like that, because it can drop the intraocular pressure by 25 to 40% if it's given orally, not as topical. So same side effects like all the others. You have, it can cause, the problem with oral carbonic anhydrase can also cause Stevens-Johnson kind of syndrome. That means people can actually die because of this. And this can very, very severe allergy. And it also can cause aplastic anemia. So if in systemic, and it also can cause renal impairment. So if we are giving Diamox, we usually give it only for a short term, but not for long term. So in case we want to bring the pressure down very fast and we're planning on our next move, whether it's laser or surgery, then we will use oral steroids, oral Diamox, sorry. So this is actually showing you, when you use all these medications, they can cause blurring of vision, tearing, stinging, bad taste in the mouth, fatigue, or drowsiness. So prostaglandins, among all this, has got the best convenience and comfort. because it's got very minimum side effects systemically. So you had one question about when would you use anti-glaucoma, or when would you use the medication? Actually, whether it's open angle or angle closure, it doesn't matter. There's no certain drug for open angle and no certain drug for angle closure. The whole idea of glaucoma management, medical, is to reduce the pressure as much as possible so that to prevent progression of the disease. So it doesn't matter whether it's open angle or angle closure, you will use all these drugs that I've mentioned earlier. Now, when will we use combination drugs? Okay, so there are many, many different types of combination drugs, as you may know. So what are we looking for? Why are we combining medications? Because I will go to the next slide in a minute, then we will tell you why. So what are we looking for in the future in medical treatment? We want better compliance. That means we want the patient to be able to put the drops on their own, and we want them to be persistent with their treatment regime. We want drugs which have got less side effects. We want costs to be minimum, and we want to arrest the degeneration of the optic nerve. So basically, we want to halt the progression of the disease and make sure that these patients don't progress from visual impairment to visual loss. Do not want them to become blind, because 4% of all glaucoma patients can become blind despite the best of treatment. So the future lies in new drugs that control the intraocular pressure. So that's one way of doing it. But then, and those that don't, because there's also intraocular pressure is the only thing that we can measure, but we actually haven't looked at the optic nerve perfusion. That means the blood supply to the optic nerve. And so there are lots of other drugs that are out there that could help to do that. So that's why we need to look at the future, and not just in terms of controlling intraocular pressure. New preservatives, new drug delivery systems. So remember, we were talking about all these new drugs: Rho kinase, prostaglandin EP2 agonist, bimetoprost. We'll talk about, we're not going to go into the details of this, but you also have a lot of common preservative. BAK is the most common, but now we are trying to go away from it. So you have purites, we have what are the other? We have so many BAK free, like Travatan and all that has all these new BAK. They don't have BAK anymore, so they have other preservatives. The reason why people are moving to other preservatives is because they want to reduce the stinging and the dryness that's associated with all these problems. So now we have preservatives such as vanishing preservatives like Sofzia, purites, sodium perborate, which actually converts to water and oxygen when they come in contact with the tear film. So they don't have BAK anymore. So other options such as multi-use bottles that prevent contamination, different drug delivery systems are being looked at. So you have non-biodegradable implants, biodegradable implants, liposomes, so many things that are out there. I would just like to say a word about bimetoprost SR, because in Malaysia, I was involved in this Artemis study. This was actually FDA level 3, and we actually injected these little implants into the eye, and over time, the implants will degrade into the, so this is actually, the implant is used with we use like an injector. We inject it into the anterior chamber, then it will fall down, and it will give out bimetoprost. Bimetoprost will be giving like a sustained release kind of thing. And usually they said every 4 months we need to inject, but some of the studies are showing that it will last maybe even a year. So it's like people who are not compliant, who live alone, they can't put the drops properly. So all these implants and everything are potentials to help. So then you have macromolecules. There's more drug delivery systems that are out there. So I just want to highlight a little bit about all this so that you are aware that there are a lot of things out there. And then we are moving forward to also gene therapy. Although they've been talking about it for the last 10 to 15 years, they actually haven't found the right gene. So, but the Rho kinase is now very promising, and it seems to be reducing pressures quite well. So that is quite a lot of stuff about your drugs. Now I'm going to talk about monotherapy versus fixed combinations. The thing is, we use monotherapy when we think that one, reduction of pressure by 15 or 25% or 30% is enough, and there's not going to be any progression, then we will use monotherapy. When we use more than one drug, when we don't get enough adequate control and the disease is progressing, then we will step up our medications. So when we step up, say for example, a person presented with an IOP of 30, and by giving a prostaglandin analog, we got the pressure down to 18 or 15, and there was no progression. So we are happy with monotherapy. But say with the pressure of 20, the patient is still progressing, then we will add second line drug. But if the patient was a young patient, for me, my preference I will not use a beta blocker. So I will then use either a carbonic anhydrase, CAI, or I will use an alpha agonist, and I will do it separately. Prostaglandin and one of these other drugs as a second line. When you use alpha agonist or a CAI as a second line, the reduction in pressure is not like the first slide that I showed you, 15-20%. It's not cumulative. It's just maybe another 5% or 10%. So as a single drug, it reduces it the way it does. But when you add second line and third line drugs, the efficacy of the drug reduces. Okay, so that's another thing that you need to remember. What is the potential advantage of fixed combination is the efficacy. Instead of putting like Simbrinza is alpha-gen, carbonic anhydrase, and alpha agonist in one bottle. So instead of me putting 3 times a day of CAI and 3 times of the day alpha agonist, we bring them into one bottle. So instead of 6 drops per day, we use 3 drops per day. And so the preservatives are less, the less side effects, and the compliance would be better. So that's what you mean by efficacy. And the tolerability is the same because we are reducing the number of preservatives that are actually hitting the eye. So that's what we are talking about in fixed combinations. The disadvantage of all these things is it actually can cause substantial financial burden because the cost of these medications are very high. And that's why we are all turning to generic drugs as well. But with generic drugs, we have to make sure that the efficacy of the drug is the same as the original drug. And now the cost effectiveness is not much. Sometimes because the generic drugs are also increasing their cost. So if they tend to increase their cost, then there's no advantage in the financial burden being reduced. So the thing is, and lots of these fixed combination drugs from before came with a beta blocker in it. So you had, you had Zalacom, you had Duotraf, you had Lumigan plus Timolol and all those things. It's like Cosopt and all those things. So all these came with beta blocker. So if you have a patient who has got a heart problem or asthma, then you don't want to use a beta blocker. So that's why the new fixed combinations that are coming about, there's Roclatan and all that, which is Rho kinase plus prostaglandin, all those are now coming up. They haven't come to Malaysia yet, but they're all coming up. So as new medications are developed for the reduction of IOP, we should expect to see companies develop additional fixed combinations to increase our options for convenience and effective medical therapy. So the possibility of sustained delivery as an alternative to eye drops presents another clear, because a lot of things that we, sometimes we prescribe medicines as 3 times a day or 2 different medicines. But the thing is, ultimately, it comes down to adherence of the patient and compliance. So if the patients say that they're going to put it, but they don't put it, then the medicines are not going to be so effective. So in summary, we're still in search for an ideal drug with very safe profile, significant IOP lowering, which will give us also neuroprotection, and without compromising the perfusion pressure. This perfusion pressure has got to do with the blood flow to the optic nerve. So all this talk that I'm giving so far, because of the constraint of it, I'm not talking about perfusion pressure and things like that. So this is, as the latest, which is the medical treatment which is the most effective and which is the first line choice for medication for open angle glaucoma? It's prostaglandin analog, by far. So everybody should be using prostaglandin analog as the first line because it reduces the IOP by 25 to 35% and it has no systemic side effects. Okay, so that's one point to tell. The cost effectiveness of management options should also be considered by physicians. So when I was in government, to be honest with you, we had some drugs in our blue book. So I could prescribe whatever that was available, and the patients don't have to pay. But in private now, the cost becomes a factor. So some people come to private not because they can afford everything, but they come for different reasons. So we need to actually find the best cost-effective measure to make sure that they put the drops and they don't default. So in conclusion, we treat individuals and not populations. So it's important for us to remember the prevalence that we talked about, but ultimately it comes down to treating an individual, no one size fits all. Precision medicine is becoming a reality in certain fields of medicine. However, it hasn't come to ophthalmology yet, but we can all hope for. And just to tell you, prevalence increases due to the aging. The incidence of getting glaucoma increases in the aging population. Open angle glaucomas are still the most common out there, but angle closures are more blinding and they are a major problem in Asia. Glaucoma is a leading cause of irreversible blindness, but although we say that, not everybody goes blind because of glaucoma. So early screening is very important and we need to look at the risk factors. Medical treatment is still first line and prostaglandins remain the first line. And we have to individualize our treatment because we always need to remember what is our goal. The goal of treatment is to maintain the patient's visual function and their quality of life at a sustainable cost. And so I would like to also end that we don't want to be going to cause them functional impairment or blindness. So we must restrict the disease process and halt it as soon as possible and as fast as possible so that the patients maintain their quality of life as long as they can. So I would just like to say that our visual field and our perception about a topic, we shouldn't be very close-minded about it, and we also should have a very, not a myopic view about things. So your vision may be narrower than we realize. And so this is actually also for visual fields, for glaucoma and things like that. But also, I would like to thank you for inviting me to give this talk because I think I just want to give a real broad overview, and I hope you kind of understand that it's not just treating an intraocular pressure. We're actually, at the end of the day, we're actually treating a patient. Just like you and me, we're all different. So each patient is different. So we actually have to tailor our management to some of these patients. And sometimes they don't realize the need for us to monitor them over time. They'll say, why are there so many, why are we doing so many tests? Why is it like if I'm diabetic, I just take my blood sugar and my blood sugar is high, I start treatment. But in eye, glaucoma, it doesn't work like that. So we need to show progression, and we need to show a relationship between structure and function. And so all these things are difficult. So that's why I didn't really talk about progression, because it's a big topic on its own. So I hope I've been able to just shed some light. So if you have any questions, please ask me. And please give me a feedback if you think, have I deviated, so that I could improve as well. Yeah. Right.
Thank you, Dr. Thaya, for the very informative talk. I think for the past 1 hour and a half or so. So if you have any question pertaining anything related to glaucoma and treatment, feel free to ask. We still got a bit more time at our hand. So
Yes, I do. Firstly, I would like to thank you, Dr. Thaya. That was a very good presentation. Actually, it
thank
gave us
you.
a lot of information. Thank you so much.
Thank you. Yeah, if I missed anything, let me know. Okay, I will. If you've got any questions that I haven't answered,
Yeah.
so let me know. Yes.
I just want to know, I'm curious actually, how long has it been since you moved from HKL to this Oasis Eye Specialist?
But I officially retired in 1st of September.
Okay.
So I was just telling Huda, so in case you all are interested, I can, if you all want me to give any lectures or anything, I'm happy to do it. It could be glaucoma, it could even be eye-related problems or anything. I like teaching, so that's why it took me 28 years to leave service, I suppose. But it had to happen.
Okay. No, I just came up with an idea because some of our GP friends, they do general screening for their patients, but usually they miss out the eye. I think a lot of things are actually underdiagnosed for the eye in Malaysia. So we can come up with a program or whatnot. We'd like to talk to you about that. But I
Yeah,
think we'll
sure.
take that.
No problem. Yes.
You-
Actually, part of our Oasis thing, we
Mhm.
actually gave a lot of GP talks over the past 1 year, because Oasis is quite new. It's actually a subspecialty place. So there's a lot of subspecialists here. So there is in VR, there's Kenneth Fong and Mano.
Mhm.
Then Dr. Sundar is here for pediatrics. Dr. John and Vanita are here for cornea. Dr. Thai is here for oculoplasty.
Wow.
Then, Dr. Wong is here for medical retina. And then we have Dr. Kaur, who's more for refractive surgery kind of thing. So actually, we have a team here. So, and I'm at the moment for glaucoma. Yeah, so that's right. So we actually have given some talks in the past to GPs regarding screening and all that. But we are we'll be, we would like to, if you want us, we can give any talks if you want, not a problem.
Okay, I guess we'll have to see your team separately on that.
Yes.
Just to go back to.
I can vouch for them as well. I'm sure if we just tell them, they will all be happy, because we all we want to educate people as well, and that's part of our thing as well.
Okay, noted, Dr. Thaya. Just to
Yes.
go back on your talk just now, I couldn't help but notice that you stressed the importance of adherence and also compliance many times. So, did you see a lot of patients who are not compliant when you were serving in, say, HKL? And
Yes,
what was the problem?
actually the patients are in Malaysia, right? People are very kind, they're very polite. So when you ask them whether they've been putting the drops, they will say yes, and they'll say they never forget. But there are lots of studies that have been done all over the world, because all over the world they have insurance giving them the medications, right? So like you have, so they actually tracked the records of a lot of these people. So instead of using a bottle which only lasts for about 5 weeks, you will see that they come and replenish their stock maybe much later. So either they're not putting the drops as regular as they say. So that means if the drops only last for 5 weeks, but then they can use it for 8 weeks, that means there are days that they are missing their doses. So there are lots of studies. Dr. Ivan Goldberg in Australia, Sydney, he's actually done so much research on compliance and adherence. So we give a lot of credit to patients and trust them that they're putting their drops, but a lot of times they may miss it. So compliance and and efficacy and all that stuff is all correlated. So, like I tell my patients, it's like you have a tree and you wonder why the tree is dying. Because actually we're not watering it in the right place. We're not watering it. We are not watering the tree. Either we are watering the tree, or we are over watering it, or we are under watering it. So, it's like that. So eye drops is also like that. So sometimes the patients, because they are old, most of our patients with glaucoma are old, and they also might already have advanced field defects. So they might not be able to put the drop directly into your eye. Have you tried, Anarin, to put your drop in your eye? Half the time you miss, right?
Yeah,
Because
it goes all over the place.
because even though we have good vision and we good visual field, so it's actually learning the technique and how to do it, and we need to spend a lot more time. So we are so quick to write a prescription, but we really don't know how difficult it is for the patients to do it, and they don't want to hurt us, and they want to seem like ideal patients, so they'll tell you that they're putting the drops, but somehow they're progressing. So then some doctors will just keep increasing the medication, increasing the number of medication, increasing the single drug to a combination drug, and we just keep adding to the masala. It's like having a dish and you keep thinking that you're going to add more salt, you're going to add more, whatever. But then that itself could cause the patient to not want to put the drops because they're getting so much of dry eye, so much of ocular surface disease, the burden of the cost of the medication. There's so many factors that we just so lightly take for granted. Because I'm not young, so over the years, you realize that, and in government service, the cost is not a factor because they're getting it for free. But yet you know that they're not putting it as much as you think they are.
Yeah. I would like to share a story, Doctor.
Yes,
This is actually
sure.
my mom's sister. She is 72. The problem is we started realizing something was wrong with her because she finishes her medicine, the eye drops. She's using Pros Drop, if I'm not mistaken. She
Yes,
finishes it in like 13 or 14 days.
yes,
So it was supposed to be for a month. So
yes,
we were actually curious because she's being ferried around between her son's and also daughter's place. So whenever she squeezes, it goes all over the place and she finishes the medicine very fast. So we have to like continuously buy, until she goes for her next appointment. Then that also affects the compliance. So she was quiet after it finishes. She didn't tell us.
yes, because she's scared that it's going to increase the cost for y'all, and and
Yeah.
yes, exactly. And so imagine if she's putting the drop so much into the eye, the
Mhm.
amount of preservatives that are actually getting into the eye is also going to be much more. So the toxicity is also going to be more. Like you're literally flushing your eye with loads of medicine. Like instead of getting 0.1%, you're getting 5%. So that also will cause ocular surface disease, because remember we talked about the preservatives in all the medications. So all these are things that all add up. So as doctors and as drug reps and all that stuff, we are very happy when we have a new drug in the market. We are very excited. Like she was just telling me about a prostaglandin that she have that we don't need to keep it in the fridge. I'm like, yeah, and it doesn't cost
Yeah.
very much because
Yeah.
it's
You know what happened, doctor? Because when I took my aunt to the clinic, right, to see this doctor, they actually gave her an ice pack to take the medicine along with.
yes,
Because so I wonder whether the cost is from the hospital or it's actually billed to her. But anyway, I think Huda has told you a lot about Optapros. She's also probably told you that this medicine has got a one drop technology, so it's no waste. So if you are open to it, we'd like to offer you samples for you to actually try the
yes,
experience.
yeah, I'm very open to it. Absolutely. Anything that's going to help our patients is something that that I'm very, very open to. And the thing about glaucoma, I just like to say, it's not a simple disease. It's not just one disease. Remember from one of the earlier sites, it's actually a collection of a lot of stuff. And it's basically a progressive optic neuropathy. So if we can halt it, we will be winning. Like Audrey asked, I mean, if you have already had glaucoma surgery, do you need to be on follow-up and things like that? The answer is yes, you need, because you don't know whether your progression is halted or whether your progression is slowly coming back. You don't know all those things. So you do need to be on continuous follow-up. Just like diabetes, if you have diabetes or high blood pressure, it's kind of like a lifelong kind of thing.
Okay.
Okay.
Okay, I think that's all for us. Thank you very much, Dr. Thaya.
You're most welcome. You're most welcome. Please come and visit us in Oasis as well.
Yeah, I'll do. Thank you.
Dr.
Yes.
Dr. Thaya, Audrey again.
Yes, Audrey. Hi
I
there.
like to ask you, what is the percentage, or what is the, what do you call that, possibility of those patients who actually undergone the surgery to have glaucoma again?
It's not glaucoma again, Audrey. You never stop having glaucoma. So although you've had the surgery, depending on what surgery you had, it will try to halt the disease progression. So say you had a trabeculectomy. Trabeculectomy means making a door in the eye. Wait, just 1 second here. I'm trying to get to the... So when you make a door in the eye, oh no. Okay. So if you make a door in the eye, you're actually creating... Can you see this picture here, guys? Can Audrey?
Can.
Okay. So this actually is like a fistula. A fistula, you know, when you go for renal dialysis, the fistula can close, you know, over time. And in glaucoma, the surgery can fail because the door starts closing. Why does the door start closing? Because scar tissue starts forming. So if I had glaucoma for 30 years and on topical anti-glaucoma medications, my risk of failure is going to be higher. So if I'm a young patient who has glaucoma surgery, my risk of failure is going to be higher because over the years, there will be parut, or what we call a scar, that will form over the trap site. And that will cause the pressure to start going up. You get it, Audrey? So yes. You can never you can never recover from glaucoma. You can recover from a cold. You can recover from, now even it's really, can we recover from COVID? God only knows. It's like if you have COVID and you survive it, you can still have long-term damage to your lungs. So although you don't have COVID in your system, but the damage caused by the COVID to your lungs is going to give you long-term damage. You get what I'm trying to say, Audrey? So glaucoma is not, unless it's a purely secondary glaucoma, it's like a one-off, like take out the steroids and the patient slowly will recover and the pressure comes back to normal. Those are things in certain secondary cases, secondary types of glaucoma, then it will be okay. But if not, generally, you will need to still monitor them over time, but maybe not so frequent, but you will still need to do it. Can Audrey?
And so, doctor, for a patient, let's say age about 83, 84, do you what is your opinion whether to go for surgery or still maintain using the eye drop?
Actually, just to tell you, right, this is going to sound philosophical because when you get older to my age, we tend to be more philosophical, Naren. I hope you realize. IOP is a number, just like age is a number. So if he's 85 years old, but he's a strong, healthy 85-year-old, which he's got a lot of life. Like you look at our Tun M, he's 90-something, but he's like a 60-year-old. So if a person like that, then you might still want to be aggressive in their management. But if it's 85 years old who's very frail and who's not doing much, his quality of life is already quite poor, then you may want to just not be so aggressive. You get what I'm saying, Audrey?
Yes.
So it all depends on each individual because not one size fits all. We don't treat based on just purely on age. We will treat them based on their quality of life and the best way that we can give them the best for them to run the remainder part of their lives. So it's not like 70 and 80, we don't need to do anything aggressive. A 20-year-old be very aggressive. Sometimes it's not like that. So you have to tailor make it for each patient. So if the person doesn't have very advanced glaucoma, he's okay with one drop, there's no progression over the years, then we're fine with that. But if the patient is on 3-4 medications and he's finding it difficult to put, there's a cost, there's a factor, then you may want to talk about doing surgical intervention. It could be laser, it could be non-invasive, it could be invasive, but there are other options for all these patients. Okay. Does it help, Audrey?
Yes, thank you.
You're most welcome. So if that's your, who are you talking about? Your parents or your grandfather or something?
My father-in-law.
Your father-in-law. If your father-in-law is a healthy 85 years old and he looks like he's going to have 15 to 20 years in front of him, then you may want to be more aggressive.
Problem is he refused to go for surgery.
Then if you refuse to go for surgery, you can also try laser, non-invasive. You can try to reduce the pressure in other ways besides medication. And laser is not, it's also as efficacious, and sometimes it gives you good results, sometimes it doesn't. It depends on whether it's open angle, closed angle, primary, secondary, all these kind of things. Okay.
Laser and surgery is the same.
No, they're not the same.
For his understanding, I mean.
Oh no, it's not. That's why I hope this introduction will give you a overview. Under surgery, you have lasers, and you have lasers are non-invasive, and surgical. When you cut into the eye, you take them into the operating theater, that becomes invasive, and we go into the eye. That is invasive. So lasers can be non-invasive, but they're surgical, they're not medical. They're not medication, but they still will come under the borderline between medical and surgical. Non-invasive. Can, Audrey?
Yeah, doctor.
Okay, dear.
Any other question from the audience? Hospital team?
Hi, Dr. Thaya. I'm Andy here.
Sorry, your name is?
Andy.
Andy. Hi, Andy.
Hi, Doctor. No, I just want to ask you, based on your experience, Doctor,
Yes.
how GP, the general practice, identify this glaucoma, and did they treat the patient?
GP means general practice,
Yes.
not the ophthalmologist.
I know, GP, general practice.
The GP, you will have to go and give them the risk factors for glaucoma, the strong risk factors and possible risk factors and all that. Then you can show them that risk factors, and then you can also tell them about the screening based on age. So if the person is a diabetic or the person is a hypertensive, got other vascular problems, they also will need an eye checkup. So maybe in that way, you can get them to the GPs to refer to the ophthalmologist. That can, but they cannot treat. They can treat if it's already on follow-up long-term and the patient is stable, like maybe Audrey's father-in-law. So the patient is only on one anti-glaucoma and is very stable over the last 5 years. Then you can go and repeat prescription with the GP. Something like that, but they cannot treat and diagnose glaucoma. It's already very difficult in an ophthalmology setup, because in order for us to diagnose glaucoma, we need to have a correlation between structure and function. So you need intraocular pressures, you need visual fields, you need OCT machines to look at retinal nerve fiber layer, you need to do a gonioscope to see whether the longkang is open. So the longkang could be open 5 years ago, the drainage system, but over the years, the drainage can get blocked, and from open, it can be narrow. So all those things you will only be able to do in ophthalmology setup. And you need to check the eye pressure using a Goldman or a proper eye care in young children. So it's not easy for them to diagnose glaucoma, but they can be aware of referring urgently if it's an acute angle closure. So if a person comes with a painful red eye, the pupil is dilated, the cornea is hazy, then they can refer acute. The rest of the time, they can refer as for screening. That would be my take how a GP can help ophthalmologists, but they cannot diagnose and treat glaucoma on their own. Not really.
Because of the machines that's required.
They won't be able to, first of all, you need to diagnose it. And then second of all, you need to monitor progression. And all these things, you need to have a relationship between structure and function. It's not like blood pressure, you just go pump and check the blood pressure and then take medicine. So even if you're hypertensive, you need to make sure that you don't have cholesterol, you don't have other vascular problems associated with it. So you also need life-modifying things. So those are things that you need to be aware of. So for the GPs, mainly if they can be aware of the risk factors, and then they can refer appropriately. Because a lot of people actually have angle closure in Asian countries compared to open angles in Western countries. But nowadays, some of the ophthalmologists, they are doing cataracts for different reasons. But sometimes we also need to do cataracts because we want to take out the elephant, the lens, which is very thick and big from a small room. So if you have a narrow angle, you may want to take out the elephant from the room. So all those are, but they'll say their vision is good. It's got nothing to do with vision. We don't want the drain to get blocked over time. So there's a lot of things like that. So is that okay, Andrew, the answer? I hope I helped.
I got it.
Okay.
Thanks, doctor.
Yeah, you're welcome. Is it okay?
Yeah. Any more questions, guys? If there's no more question, then I would like to say thank you, Dr. Thaya, again for her time and for giving us, enlighten us on the disease glaucoma and the treatment that are available in Malaysia. So hopefully this training will be helpful for you guys with our optacross, and hopefully it does give shed a light on the disease itself. Okay. So if there's no more questions, then thank you everyone for your time, and thank you again, Dr. Thaya.
Yeah, you're most welcome. Just like to say that now there's this new drug, but it hasn't come yet. Rho kinase is in the market already. And even your prostaglandin, the epicenoid, the Omida pack is also coming. It's already been, it's not approved in Malaysia yet. But they've already had some talks about it. So those are two new kind of drugs. But the Omida pack, which is the FP2 thing, the weird thing is you only can use it in phakic eyes. So I don't think it's going to really catch on, because a lot of patients who we have might be pseudophakic. So pseudophakic is a contraindication. But Rho kinase is very promising, Roclatan and all those drugs. So there are lots of other new combination drugs out there as well. Okay, so I'd like to thank you, and I hope it was informative, and hope you learned something. So if you feel that you need to let me know anything, you can just WhatsApp me or help me, tell me what I didn't do. Okay, so bye guys. Thank you very much.
Thank you guys.
Thanks.
Thank you.
Thank you.